Focus 8 is protection.
The definition of protection is the combination of the body's primary and secondary defenses used to prevent injury, illness, or harm.
Factors affecting protection include things like age, genetics, nutritional status, as well as environmental exposures. Why are children at risk for protection problems? Well, they have very fragile skin, and developmentally, young children require the use of diapers. They tend to receive a lot of injuries or hurt themselves, and so those developmental considerations are a very big part of the anticipatory guidance that we see used with young children. Some children will also have inherited medical conditions. All children in general have an immaturity of the immune system functioning. The child may develop some autoimmune functions, and some children will have transmission of infections during the birth process. With our spectrum of protection problems, we will discuss skin alterations, genetics, as well as hematological and immunological function. The significance of the skin is very important. It is the sensory organ through which the infant first experiences the world. It can signal danger in the form of pain to the inquisitive toddler who's exploring his environment. It is the human armor of the 4 or 5-year-old who admires superheroes and fears his own vulnerability. And it is the outer layer that the adolescent recognizes as the me in the mirror. Skin is decorated and tattooed to give personal uniqueness. Now, wounds are structural or physiological disruptions of the skin that activate normal or abnormal tissue repair responses. And so some factors that disrupt or delay wound healing include things like inadequate nutrition, poor tissue perfusion, as well as infection. With the process of wound healing, there are 4 phases that we see. So initially the skin is injured and the normal protective barrier has been broken. When this happens, the first phase is hemostasis. And this is where the platelets are activated to seal off the damaged blood vessel and form clots. It occurs within minutes unless there is some sort of underlying clotting problem. The second phase is the inflammatory response, and during this phase, the white blood cells are activated to mount a defense against any microbials that have entered the wound. The white blood cells secrete enzymes that destroy the non-viable tissue and microorganisms within the wound area. And usually in this stage, we see erythema, edema, warmth, as well as pain at the site of the injury. Around day 4 through day 21, we see the proliferation phase. And this is where we see the replacement of the dermal and the subdermal tissue. Usually it's replaced by granulation tissue or that is beefy red in nature around the wound base. The 4th phase is the remodeling phase, and this stage occurs in the dermis. We see the fibroblasts that are increasing tissue strength, and then a mature scar is formed, and that scar will change in appearance and in thickness over the next several months. Wound care basics include washing the wound with mild soap and water and rinsing thoroughly. In this case, we're not actually putting soap into the wound, we're just washing as we normally would. We want to cover any open wound. So if it's a small wound, an adhesive bandage such as a Band-Aid is appropriate. For a large wound, an occlusive dressing will be required. And it's important to leave a wide margin of intact skin around the dressing, but we don't want the dressing to be so large that it covers like all of the chest or all of the arm. We only really need a 1-inch margin around the wound to be in contact with the adhesive that holds the dressing in place. If there's a lot of leakage, we want to remove that dressing, and we want to remove it carefully to prevent the destruction of any new tissue that has formed. Now, itching or pruritus is the most common complaint that we see with skin lesions, and this is caused from the new tissue that's being formed. Now, some cooling baths or cooling compresses oftentimes will help quite a bit with itching. For younger children, we definitely want to prevent scratching or picking, and really picking in any age group, because of the likelihood of transmitting any bacteria from the fingernails or on the skin into the wound. So, mittens might be appropriate for younger children to prevent scratching, keeping the fingernails trimmed shortly, and then either using a topical or a systemic type of antipyretic medication, such as Benadryl or some of the non-drowsy formulations of anti-inflammatory or anti-itch medications. Contact dermatitis is an acute onset of intensely pruritic or itchy papulovesicular eczema rash in patches or streaks localized to the site of contact. A lot of times we can see this type of reaction as an inflammatory reaction to skin from a chemical. And the clinical manifestations include a sharp delineation between the inflamed and the normal skin, as well as itching, stinging, burning, and erythema. Examples include things like diaper dermatitis from stool or urine laying in contact with the skin, a reaction to clothing such as wool, a reaction to specific chemicals such as laundry detergents or soaps, as well as bug bites and latex. The treatment for contact dermatitis involves avoiding the irritant. For example, if a child is exposed to something like poison ivy or poison oak, the child will need to have that skin rinsed with cold water from a minimum of 10 to 15 minutes. Also, the child's backpack or clothing or whatever they were wearing would also need to be washed appropriately so that the oils from the poisonous plant are no longer on those materials and they will avoid getting another infection or another irritation from it. Hydrocortisone cream may be prescribed for 7 to 10 days. The child may require some antihistamines to prevent secondary infections from scratching. And again, there are a lot of over-the-counter preparations in the form of baths or soaks, as well as some anti-itch lotions that can be very helpful in treating the dermatitis. Diaper dermatitis is characterized by erythema and skin lesions, usually from irritation of urine and feces. However, it could also be related to a child who is using cloth diapers where the detergents have not been completely rinsed from the clothing. Could also be from a chemical type of irritation, especially from things like diaper wipes. Now, there are diaper wipes that are marketed for sensitive skin. However, those diaper wipes do smell nice, and so there is some sort of chemical or smell that's associated with them that could potentially also cause a chemical irritation. Medical management is based on the severity of the diaper dermatitis and involves thoroughly cleaning the skin and allowing the skin to dry, and then applying a heavy emollient type cream, such as Aquaphor or Desitin or A&D ointment, something to create a barrier with each diaper change. Now, for some children, they may require the application of a topical steroid. That would be applied before the heavy emollient was applied. They may also be requiring something like a topical antifungal if they have something like a candida infection in the diaper area. The steroids or the antifungals may be used together, however, they would need to be alternated with different diaper changes. And again, the heavy emollient cream on top of that. With diaper dermatitis, we want to avoid continuous moisture and excessive heat by changing those diapers frequently. We want to keep the skin dry and allow it to air dry before applying any type of ointment or cream. We want to cleanse the skin with warm water and a very, very mild soap. And that would be to avoid any kind of perfumed diaper wipes. So you might see a parent using something called a soft net, which is essentially a disposable washcloth, and water in the hospital setting. Or even a wet paper towel that doesn't have any other chemicals on it might be appropriate. If the child does require soap, only something very, very mild, such as a Dove soap. Those protective ointments include things like zinc oxide, Desitin, Balmex, Aquaphor, A&D ointment. There are a number of products that are available. This slide takes a look at two different children who have a fungal infection of the diaper area. And this would be a yeast infection. Usually with a regular type of diaper dermatitis, you would see clear boundaries of where the urine or stool touched the skin. However, in the case of a candidal or a fungal infection, the boundaries are less clear and you can see little red dots or little white papules in some cases that have jumped across the inguinal folds and are now in areas where the urine or stool may not necessarily come in contact with the skin. So with these types of yeast infections, they generally have a fiery red, papule with peripheral scaling appearance, and there may be some pustules associated with that. The satellite lesions are those little red dots that have jumped across those inguinal folds or not in direct contact with skin that it was in contact with urine or stool. Now, when the child is assessed for this, we also have to assess not just the diaper area, but also the mouth, because it could have been an oral thrush that has worked its way throughout the GI system and ended up with clear presentation in the diaper area, or infection in the diaper area could kind of travel back up and cause an infection within the mouth. We may need to alternate the topical nystatin or clotrimazole with something like a ketoconazole cream with hydrocortisone, and so they will be on that a couple times a day. And then we're going to be doing the same things that we were doing for diaper dermatitis, so changing those diapers frequently, allowing the skin to be cool and dry, applying the medicated treatments, and then putting the heavy emollient creams on top of that. Atopic dermatitis is also known as eczema, and this is a skin disorder that is characterized by acute and chronic skin eruptions known as eczema. Now, oftentimes the children who have eczema tend to have a history of asthma-like signs and symptoms in their past, as well as allergies. So eczema, allergies, and asthma kind of all go together. What we see is an erythema, edema, as well as papules and weeping in the active phases of eczema. And as that skin goes through this process where it becomes red and irritated, and then it heals, and then it happens again, we see scales form. And there's also a process called lichenification. And the lichenification just refers to skin that has become thick and tough and leathery from repeated infections of the skin. Eczema is extremely itchy, and so it's very, very difficult to prevent children from scratching and from causing secondary type of bacterial infections within those areas that are affected with the eczema. Some of the triggers that cause eczema include excessive bathing and hand washing, and we oftentimes see some eczema signs and symptoms in adults who work in healthcare from the frequent hand washing and redness and irritation on the skin, as well as occlusive clothing. So we definitely need the skin to be able to breathe, and with excessive bathing, we really need to just get the job done, get in and out, and use minimal soap when giving a child a bath. Now here are some pictures of atopic dermatitis. You can see the child on the left-hand side of the slide has that red, irritated skin, and that skin does have a leathery appearance to it. So this child has the lichenification that I was describing previously. The child on the upper right-hand side, you can see has a milder form on the cheeks and around the mouth. And this is not uncommon, especially during the winter months, as the skin becomes a little bit more dry. Also, young children are frequently having their faces and their nose wiped, whether it's due to cold-like symptoms or between meals, and so that increase in friction and irritation of the skin can occur. The bottom picture on the slide shows you the most common areas where we see eczema. Now, it can occur anywhere on the body, but the face, the elbows or the forearms, as well as the knees are the most frequently affected due to the friction associated with crawling especially. Therapeutic management of eczema involves relieving the itching, and that can be accomplished with either a topical or a systemic form of Benadryl. However, the systemic form of Benadryl can cause drowsiness, so that's not something that we would want to give all the time. And if we did give that, we'd want to give that at nighttime before bed. Hydroxyzine is another type of anti-inflammatory, anti-itch medication that does not have the drowsy side effects, so that's a good choice for children who have eczema. We also want to make sure that we're hydrating the skin. That is the most important thing that we can do for children with eczema. So when we do our bath, we're going to do a quick, short bath. The water needs to be mild in temperature, so not too hot. That causes some excessive drying. Only use soap on the body parts that require it. Once they're out of the tub, you just pat them dry. They don't need to be totally dry. You just pat off most of the moisture, and then you start applying the heavy emollient creams on top of the skin to trap that moisture in the child's skin. And some good agents to use for that would be Eucerin or Aquaphor. Now, a little bit of application goes a very long way because it's a very greasy type of ointment. So you'd want to make sure that you use a little bit, get it worked in well to the areas that need it the most, and then get the child dressed. In cotton clothing is preferable. If you're seeing redness or irritation, rough patches on the skin, hydrocortisone cream can be applied, followed by the application of the Eucerin or the Aquaphor. We want to prevent or control any type of secondary infection with these children as well. So if we're able to keep their skin covered and have them wash their hands to minimize the number of microbial agents that could be on them when they're scratching, that would be helpful. Also with treatment, we want to keep the skin hydrated and keep the itching under control. We want to avoid the irritants, so providing them with cotton clothing that allows the skin to breathe would be best. Avoiding fabric softener is key here, and using a very mild laundry detergent is helpful to prevent any kind of skin irritation related to that. The very short baths followed by the application of the lubricants. Only mild soaps on the body parts that need it, and then the different products to apply to the skin are shown there for you. Seborrheic dermatitis is also known as cradle cap, and this is a greasy, salmon-colored scaly dermatitis that's usually found on the crown of the head, but it also can be seen on the eyelids and the eyebrows. This is caused by an overproduction of sebum. Seborrheic dermatitis is characterized by erythematous, dry, scaling, crusting lesions with or without a greasy, yellow appearance. It's fairly common during the first 2 to 10 weeks of life, and it usually is completely resolved by the time a child is 1. This picture here kind of shows you very nicely of what seborrheic dermatitis looks like. There is quite a lot on the top of the head and toward the back, but if you look on the forehead, there is also some present on the forehead. Treatment involves keeping the hair dry and the head dry, shampooing the hair using a very soft bristle type brush, and these are the kinds of hand hygiene kits that you'll see used in the surgical areas as well as in the NICU for scrubbing the skin to remove as much dead skin and much debris, bacteria as possible. And we also use that to get underneath the fingernails well in the surgical and the NICU areas. So it's a very, very soft brush that's made out of plastic that's used. Now for severe cradle cap, usually we tell parents to apply baby oil to the child's scalp and let that kind of sit and soak in for about 15 minutes. Once that's happened, they can do shampooing of the head with using that brushing action, but they need to know that they're not going to get it all off with just one application. It's going to take several different repeated hair washings with the baby oil scalp soaking in, that baby oil soaking into the scalp on several different occasions to be able to remove it, and they may not be able to remove all of it. If it's an older child who has seborrheic dermatitis, there is a shampoo that's marketed called Selsun Blue that can be used to treat it. Next, we have a case study. Joey is a 7-year-old boy who comes to the school's nurse's office with a complaint of an itchy rash on his face. You are the school nurse, and you assess the rash to be reddened papules and pustules with a yellowish crust occurring around his mouth and nose. What diagnosis do you suspect for Joey? And what signs and symptoms of Joey's reflect the diagnosis? Well, in this case, it's most likely that Joey probably has an impetigo infection. And that is characterized by the yellow crusty lesions, and there could also be some vesicular pustules that are present. As the school nurse, what would be your first priority? Well, infection control would be our first priority here because impetigo is very contagious, and the child may touch a lesion on their face and touch another area of their body and then have a subsequent infection in that other portion of the body. So strict hand washing would be very important, and avoiding having the child touch the area will to help prevent infection. What kind of medication do you suspect Joey's physician will order? Well, usually penicillin is the antibiotic that's the treatment of choice for severe or extensive impetigo. There is also a special solution called a Burroughs solution that little compresses can be made to apply to those impetigo lesions to soften and remove any underlying skin or crusts or debris that are present. They may also apply a bactericidal ointment on top of the lesions once they've been cleaned with the Burroughs solution. What should you educate Joey and his parents regarding the rash? Well, the skin should be kept clear and dry, and because of its highly contagious nature, any towels that Joey uses should be kept separate, and they should be changed daily. Because it is spread through direct contact, it's important that he not touch those lesions or have anybody else touch those lesions. Good hand washing is going to be very important, and if the child is taking medication, they need to take that medication as prescribed and complete the entire dose of antibiotics and make sure that the infection is completely resolved. Now, usually Joey will be able, a child of Joey's age, once they've been on antibiotics for about 24 hours and those crusts have completely cleared off, they usually can return to school. Acne is something that we typically see in the prepubertal area that's starting, and it becomes the most significant problem in the adolescent years. Now, the pathophysiology is related to a disorder of the sebaceous follicle, where there is excess of sebum, keratinous debris, and bacteria that are accumulating that produce the microcotomes, or whiteheads. Now, acne management is individualized depending on the gender, the severity of acne, as well as the different types of lesions that are seen and where they are throughout the body. Also, we want to consider what treatments have been effective for the child. So if a child has mild to moderate acne, the pediatrician may prescribe something like retinoic acid or Retin-A, which the child initially would start taking every other night for several weeks, and then nightly. They kind of have to work up their tolerance to it because it can be very irritating to the skin initially, and it can have quite a drying effect on the skin. So the child would need to avoid sun exposure because of the increased sun sensitivity, and also make sure that they're applying moisturizer to the skin. The physician may also recommend that the child start using benzoyl peroxide, which is available easily over the counter, either every day or twice a day, and they may also alternate that with the Retin-A. Now, both of these agents will dry the skin out. If they're both being used alternatingly, it can really dry the skin out. Some teaching that is required for children who are taking the Retin-A creams are that they only need a pea-sized amount that is divided equally to those 3 main areas on the face that have the highest incidence of acne, and that's kind of the T-zone on the face. This should be applied at nighttime, and the child should be instructed to wash their face first and wait a good 20 to 30 minutes after washing before they apply the ointment or the cream. And this will help to decrease the burning sensation that they may experience. The child needs to make sure that they wear sunscreen when they're out in the sun, and they need to try to avoid the sun as much as possible by wearing a hat or staying covered up. Now, benzoyl peroxide generally doesn't have as many symptoms, but it can dry out the skin, and it can also bleach out whatever it comes in contact with. So some children may accidentally bleach their eyebrows or their hairline. They may bleach out their clothing or their bed linens. So it's important that they understand how to apply that and to minimize some of those problems. So therapeutic management can be achieved through topical antibiotics, and those are usually of prescription in nature. They can also have systemic antibiotics that are used for more moderate to severe acne, the type of acne that's more likely to cause scarring. If the child is unable to take or tolerate the topical treatments, sometimes systemic antibiotics will be used in low doses. And any child that has acne on the back, shoulders, and trunk, or the chest may also need to have the low doses of systemic antibiotics. Now, for females, there is a birth control pill called orthotricycline that can be used to regulate the menstrual cycle and prevent pregnancy, but it has a side effect in that it really does a nice job with clearing up the skin. So if a child is taking birth control pills, it could be for the side effect of the skin. The last one that I want to discuss is Accutane. And Accutane is a medication that is used for children who have really severe acne, or if they're unresponsive to those usual treatments that are not effective for them. Now, if a child is going to take Accutane, it's a pill that they usually take for maybe 4 or 5 months at a time. And they need a lot of education about Accutane, because if a child should become pregnant while taking Accutane, or if an adult would become pregnant while taking Accutane, it can cause really severe birth defects. So the child would need to have a psychological evaluation completed prior to taking the Accutane, and that's due to some children and young adults who experience suicidal thoughts while taking Accutane. They need to sign a statement saying that they either will abstain from sexual activity or they will use 2 different methods of birth control during the duration of their treatment. And they need to make sure that they're having some liver enzymes tested, usually once a month during treatment, to assess for any liver complications that may occur. Now, Accutane is very good for skin problems. However, it can cause a lot of bad side effects, like very drying of the skin and the lips and the eyes. Some people will lose their hair. There could be scaling that happens. Some people can't wear their contact lenses during treatment. And other people will have those suicidal thoughts or may actually try to attempt suicide while taking this medication. So it's a medication that does work well for people with very bad skin disorders, but it's not without risks. So the child and the family need to be talked to specifically about what those side effects are and to report them immediately if they're experiencing them. Other acne nursing interventions include education about dietary habits to promote wound healing or acne healing, teaching about the importance of taking showers and removing sweaty clothing immediately after physical exercise to limit the likelihood of bacteria causing acne to occur. Emotional stress can make skin signs and symptoms worse. We talked about how to apply Retin-A and the procedure for performing that. Children should be warned that once they start a new acne regimen, sometimes their skin actually gets worse at the beginning, and it could take 6 to 12 weeks before they're starting to see significant improvement. If the child should happen to be on an oral medication for acne like tetracycline, they may need to take that on an empty stomach to promote absorption. True or false? A complication that may occur with acne and most types of dermatitis is cellulitis. This is in fact true. Burns are injuries to one or more layers of the skin and the underlying tissues that cause varying degrees of damage. Now, in the toddler age group, hot water scalds are more frequent. With older children, they may have flame-related injuries, especially if they're playing around with fireworks or lighting off fireworks or playing with matches or lighters. There are some children that have burn injuries as a result of child abuse. And there are children who accidentally set houses on fire and those sorts of things that inadvertently have some severe burn injuries in addition to the destruction of the house. Characteristics of burn injuries. When we take a look at them, we're looking at the extent of injury, which is described as the total body surface area. And there are specific age-related charts that we use to determine what percentage of the body the child has burned based on their age. We look at the depth of injury from 1st through 4th degree, and then we also look at the severity. So what percentage of the body is considered a major burn? That would be 20%. 10 to 20% would be considered a moderate burn, and less than 10% would be considered a mild or minor burn. A superficial or 1st degree burn is where the skin or epidermis is red and tender. It may be swollen, but generally no blisters are present. There may be some mild edema. It's very painful, and usually it spontaneously heals within 5 to 10 days. Most of the time there is no scarring that's present, and there are minimal systemic effects. In this case, prevention is the priority, and the child may need to limit their sun exposure time, wear covering clothing that covers their skin, and apply sunscreen. Now, sunscreen is generally safe for most people. However, an infant has to be 6 months of age or older before sunscreen can be applied. It's preferable to use the infant or baby preparations of sunscreen in younger children due to the different products that are within the sunscreen being less irritating to the skin. Treatment for a 1st degree burn might involve something like the administration of a cool gel, like a lidocaine-based gel, to the skin. Some people say that putting it in the refrigerator makes it extra cool and so it feels better on application. Tylenol or ibuprofen may be appropriate if the child is complaining of a lot of pain. This slide is in your textbook, and it takes a look at the different levels of the epidermis, the dermis, following down into the fatty tissue as well as down into the muscle and the bone. Partial thickness burns are described as 1st and 2nd degree burns, and the full thickness burns are 3rd and 4th degree. I like this slide because it goes through where those different layers are in conjunction with the wound appearance, the sensation, as well as the course of healing. Our partial thickness burns, or second-degree burns in this case, are where the epidermis and the dermis are damaged and blisters are formed. If blisters rupture, the skin is moist, but it's discolored. Now, these second-degree burns are very painful and sensitive to touches or changes in temperature or air exposure or even light touch. Usually this heals within 14 days, and it is possible for the child to sustain scarring. This picture is an example of a child who has had third-degree burns, and the outer areas of the burn appear to be second and first-degree burns. But the center of the burn, where it's red and irritated, and it appears that there might be some blood clots present, are where there's third or full-thickness burn. So this damage extends down into the subcutaneous tissue, where the nerve endings, the sweat glands, and hair follicles are involved. And there can be various color changes from red to tan, black, brown, or white. Now, the pain from the surrounding injured skin is from the surrounding injured skin, and that would be more the first and second degree burns, but the full thickness area is not painful due to the destruction of the nerve endings. Full thickness burns, the fourth degree burns, the burn has extended into the muscle, to the fascia, and possibly the bone. The skin has been charred and is black in nature, and it is not painful at the full thickness area, but it can be painful in the first and second degree areas surrounding the area. This slide takes a look at the age-related charts that estimate burn distribution. And what's interesting to see is that on the two different charts, letter A is the head, letter B is the thigh between the knee and the hip, and letter C is between the knee and the ankle. Now, depending on the age of the child, those percentages change quite a bit. For example, if we're looking at letter A, which is half of the head, this could be the front and the back of the head or side to side of the head. At birth, the head is 9.5% of the total body surface area. By the time a child is 5 years old, it's now down to 6.5%, and by the time a child has achieved adulthood, one half of the head is 3.5%. When you take a look at letters B and C, the older the child gets, those percentages will increase. Now, inhalation injuries are trauma followed from an inhalation of a heated gas or any type of toxic chemicals produced during combustion. Signs and symptoms include things like singed nasal hairs, wheezing, hoarseness, and an increase in respiratory secretions. Now, some of these signs and symptoms may not be apparent for the first 24 to 48 hours, so it takes a little time before we start to see the longer-term effects of inhalation injuries. Usually we don't see heat damage below the levels of the vocal cord because a child's airway is funnel-like in nature, where it's larger at the top and narrowed at the bottom. So the likelihood of the heat damage extending below that funneled area or below the vocal cords is very rare. Complications of all burn injuries include an immediate threat of airway compromise. There is a systemic response involving increased capillary permeability, which causes fluids to deposit into the third spaces and causes edema. The child may have profound shock from hypovolemia from the fluid accumulation in the tissues and third spacing. And lastly, they may have infection, either locally at the site of infection or potentially a systemic type of sepsis. With our burn management, our priority in care is to stop the burning process and smother the fire. Now, usually in grade school, children are taught this very easily in the stop, drop, and roll campaigns. But for healthcare providers, we also need to consider what additional interventions might be significant. So that could be something like applying cool compresses or having the child run their arm or whatever the exposed portion is under tepid water. We also want to assess the victim's airway condition, so we want to look at their airway, breathing, circulation, maintain their airway and ventilation, and maintain their vital signs. With maintaining the cardiac output, we're looking at providing the maximum amount of tissue perfusion possible. So that can involve massive amounts of fluid and electrolyte replacements, as well as blood sugar management. Now, initially, the child's blood sugar will be quite high as a result of the severe trauma to the body. But after the first day or two, the blood sugar may become unstable and may drop as the liver is not able to manufacture all the sugar that's required for a child who's in an increased state of metabolism. We need to assess the child for hypovolemic shock, and one of the easiest ways that we can assess that is by placing a Foley catheter and assessing the amount of urinary output. If the child is not having the minimum urinary output that we require for them, then the likelihood that they're not getting enough fluid is pretty high. We want to keep the wound covered to prevent infection or contamination and provide pain management to deal with the extensive amount of pain that the child may experience. Therapeutic management also includes providing the child with adequate nutrition because the child will have enhanced metabolic demands. They require a large protein intake and caloric intake as well as vitamin supplements. The child may be on systemic or topical antibiotics. They will require a number of analgesics or anesthetics for procedural pain and may need to go to the OR to have things like debridement performed. We want to maintain the child's correct body alignment to prevent contractures or skin breakdown that could, as a long-term effect, limit the child's mobility. In the picture you see, the healthcare provider is wrapping the patient's fingers to help keep them in an extended position. If that child's hands or the client's hands were to remain in a flexed position during the healing process, that patient may not be able to fully extend their fingers once the tissue has healed. Care of major burns involves a primary excision and debridement of the damaged tissue, which helps promote new tissue growth and decreases the risk for infection. So there are a number of different types of antimicrobial agents that can be used in a topical format. I'm thinking of the silver Silvadene cream. Children who have had that applied say that it burns and it stings when it's in place, and it may cause a little bit of exudate to be produced. So keeping that skin covered once the antimicrobial agent is applied will be appropriate to prevent sticking to clothing or having a lot of drainage on the child's clothing or bedding. There are a number of biological skin coverings in the form of an allograft or xenograft. There are some synthetic skin substitutes, as well as some split thickness skin grafts, in which case the child will have two wounds to care for, the donor site and then the grafted site. A child is brought by his parents to the emergency department with first-degree burns to his shoulders from sun exposure. Which of the following interventions are indicated for this type of burn? The best answer here is letter B, apply cool, wet compresses. The child may also benefit from a aloe vera or lidocaine-based aloe vera gel that can be placed on the skin and may benefit from some Tylenol or ibuprofen as well. A child experiences third-degree burns to both of his legs after they were immersed in boiling water. Which of the following nursing diagnoses will receive priority during the first 24 hours? The best answer here is letter A, deficient fluid volume. And this is because there is an extensive portion of the body that has been affected, and the amount of swelling and leakage of fluid into the third spaces can be quite high. At this point, we don't have any concerns for impaired breathing pattern. However, that would be something to keep in mind once the child has been fluid resuscitated, as there could be some swelling that occurs within the airway due to the large amount of volume of fluids that are administered. So our priority initially would be deficient fluid volume. A child is scheduled for debridement of leg wounds. In what order should the nurse perform the following procedures? Well, first of all, we want to medicate the child for pain so that while we are gathering our supplies and getting ready for the dressing change, that pain medication has had an opportunity to kick in. Then we would assess the child for the dressing supply needs. We would want to loosen up the dressing and then remove the dressing and perform the dressing change. Rehabilitation after major burns begins once that wound coverage has been achieved. So if the child has had some sort of graft and the child is stabilized and recovering, then we start doing the rehabilitation phase. So it's important to prevent and have management of any type of contracture with the use of physical or occupational therapy. The multidisciplinary team approach would involve a number of different disciplines, including the burn specialist, the skin nurse specialist, ICU treatment, social work, case management, and a number of other people to be able to completely perform the child and family's assessment and give them what they need. Additionally, we need to help facilitate adaptation for the child and family. Depending on the extent of injury, the child might have a lot of scarring to deal with. They could potentially have a loss of a limb as a result of a severe fracture, as a severe burn. So there are a number of different considerations that the child may have to go through, and they can have a lot of challenges to their self-image and their self-worth. Scabies is an infestation of the scabies mite. And the inflammatory response and itching that occurs happens 30 to 60 days after the initial contact with the host mite. So a family could be traveling someplace and stay in a hotel someplace, or be staying with a family friend or someone, and a month or 2 months after the exposure, the signs and symptoms might appear. The child complains of itching, and what we may see is a grayish-brown mite with a black dot on the end of it. Now, treatment involves preventing secondary infection because these little scabies mites actually burrow underneath the skin, and sometimes we can actually see a little bit of like a line underneath the skin from where that mite has burrowed. Treatment involves permethrin 5% cream. This is a similar type of medication that's used for head lice. However, it's in a much higher concentration. It's the 5% cream. So the child and family must bathe. Once they have bathed, they apply this cream head to toe, where it must stay on the skin in contact for 8 to 12 hours. Once that period has been completed, then they can take another shower and wash all that off. The child and family may require an additional application of this cream several days to maybe a week later. Tinea infections are also known as ringworm, and ringworm can affect various different parts of the body, and that's why we see the different types listed on the slide. Generally, we can see a round or oval erythematous patch that may have a slightly purplish quality to it. It's generally very itchy, and treatment may be topical with a topical antifungal cream. However, more significant or serious cases involve the use of oral griseofulvin, which the patient has to take for several weeks, and have kidney function tests and liver function tests monitored. If the child is having an infestation in the hair, there are special selenium sulfide shampoos for the hair. However, it is kind of difficult to treat fungal infections within the hair shaft, so that child may also need to be on the oral medication. Prevention of ringworm is very important because it's fairly contagious, and a child may develop ringworm after contact with mats in a gym class. They could get it from a school bus. They could get it from wearing clothing that someone else had worn. So teaching about not sharing hats and those sorts of things, and then careful assessments for children who spend a lot of time in the gym. I'm specifically thinking of wrestlers, tend to come down with ringworm quite frequently. So that would be thorough assessment of the skin and early detection and treatment of ringworm. A mother of a 3-year-old arrives at a clinic and tells you the child has been scratching the skin continuously and has developed a rash. The nurse assesses the child and suspects the presence of scabies. The nurse bases the suspicion on which finding noted on the assessment of the child's skin. The best answer here is letter B, fine thread-like lines. Clusters of fluid-filled vesicles might be something like a herpes type of infection. Purple-colored lesions are more likely to be ringworm, and children with thick honey-colored crusts may have something like impetigo or even varicella. Sandra is an 8-year-old girl who comes to the school's nurse's office after a teacher noticed several white nits in her head. You are the school nurse and assess the head and do confirm the child to have an infestation of pediculosis capitis. What is the lay term for pediculosis capitis? Well, that would be head lice. And what is the diagnostic evaluation to confirm the presence? That would be visual confirmation on the hair, and there could also be some scratching marks on the child's head from where the child was itching at it. You'd also want to assess for any type of secondary infection. What is the treatment? The treatment is known as a permethrin 1% or Nix shampoo, and that shampoo will only kill the live lice. It does not kill the eggs. So we want to make sure that we're following the instructions on the packaging, ensuring that we're not getting any of this shampoo in the child's eyes. You have to leave it on for the recommended amount of time, and once the child's hair has been washed, there is a fine-tooth comb that's included in the kit where every single strand of hair must be combed through to remove all the eggs that could be present in the hair. What should the nurse tell Sandra's family on how to prevent the spread? Well, they need to machine wash all clothing and towels as well as bed linen in hot water and dry for at least 20 minutes in a hot dryer. Anything that cannot be washed should be dry cleaned or sealed in a plastic bag for 14 days. If those items can be thoroughly vacuumed, they should be done so at that time. And then once they've done the treatment, the comb would either need to be discarded or they would need to boil it in hot water for a minimum of 10 minutes to kill any existing eggs or any residual matter that's on that fine comb. How do we prevent future outbreaks? Well, the child and family should be taught never to share hats, scarves, or combs, and they should avoid any type of physical contact with somebody who has this type of infestation.